We are now live.
Great. Is Dr. Clifton with us?
Yeah, I'm just letting people trickle in real quick, and then I'll get going.
Good evening.
Hey. All right. Well, we'll kick this thing off. Thank you, everyone, for coming to the second virtual webinar. We have a really, really special guest with George Athwal here today. Briefly, before we introduce everyone, just want to give a little overview of what we're going to do today. We're going to start with the Glenoid exposure, and George is going to be giving us his pearls here. And then we're going to go to an anatomic demonstration, and then we're going to go to a Glenoid. So, as I said, George is here from London, Ontario. The most impressive thing about George is he has over 350 publications, but bench presses over 375 pounds. So he over bench press to publication ratios, which you always want. We have Jay Levin here, who's going to be my partner at Duke next year. Jay is a savant in the shoulder arthroplasty field, and we have Ryan Laura here, who's at MGH, who is also an up-and-coming rising star, who's an expert in the VR space. And as always, Danny's here with his team. So, Danny, you want to give a brief just intro on VR and the initiatives you're doing?
Yeah, thank you, Chris, and thank you to Dr. Athwal, Laura, and Levin for being here. It's really exciting the ability to be able to connect with peers from anywhere around the world virtually, even though they're all in their same homes, and practice the personalization of what we do in our practice with others in a much more scalable and accessible way. And as we sort of continue to build content for our partnership with the American Shoulder Elbow Society, is going to be a lot more arthroscopy coming through. We have our BodyWorks application, which is anatomy focused, which will be utilizing quite a bit with the ASES. And then, of course, we have a large initiative around the fracture aspect of things. So thank you again, Chris, for you and Grant for this partnership with the American Shoulder Elbow Surgeons.
All right, thank you, Danny. So let's see if we could jump into this module now. And then, as always, I'm going to be moderating. So please send me any questions in the chat, and we'd be happy to relay them to the team. They're going to be speaking and going over VR and kind of how it's intended to be. It's going to be very interactive. They're going to be asking George questions, really peppering him and seeing if we can make him nervous, which is almost impossible to do. So you all want to get started? Looks like you're in the space.
Yeah, that'd be great. Thank you for the introduction. So here we're in the virtual operating room. We jump right into the exposure. Thankfully, the humeral head cut has been perfectly made for us already. And so we can, I think, first questions I wanted to get through, Dr. Athwal, Dr. Lohr, patient positioning, for you guys, for anatomic or reverse, how do you optimize the position of the torso as well as the arm for exposing the glenoid?
I can start. I can certainly engage my practice quite significantly in that second. Initially, I used to think that patients very similar to what you see here, almost like it's there. I always had issues, challenge for pressure down that's much more broader than
Dr. Athwal, can we get you to face your computer and then press and hold the flat button on the right controller again?
Sorry, I'll try that again. How's this?
Yeah, you sound much clearer.
Much better.
And then you can teleport yourself closer. It's okay.
Basically, what I was saying is I just adjusted my beach chair position to go a little bit more lower to about 20 degrees. And that way, the anesthesiologist, they're not so nervous about it. I like to keep the scapula unsupported, and I use a very similar arm position as you see here. So, yeah, very similar to what I use upper, other than just a little bit more up to 60 degrees. I'll drop it down to.
I like it a little bit more upright just because I feel like I have bad posture anyway, so this makes me stand up a little bit more. And then one thing that I like to do is with the dynamic arm holders, I'll actually take out the kidney bolster on the side just to assure that if I am adducting the arm or doing any sort of aggressive maneuvers that I don't have any weird impingement going on. I'm frustrated.
Brian, how many times have you dropped that dynamic arm holder on your foot this year? Because I seem to do that all the time.
Yeah, not that many now, but you got to make sure everything's really locked up, and you got to know your equipment. And I would tell everyone that when you're setting up the beach chair, you should double check everything, touch all the knobs, because then if anything goes wrong, then it's on you. So be the captain of the ship when you're setting this up.
It's funny that you bring that up. Mine has a pedal, so if the pedal's anywhere near me, whenever I want to move the arm or not, I end up depressing it. So now what I do is once I positioned it, I actually turn the pedal around so I cannot depress it.
Damn it, George, you're so smart. I'm going to do that. Good.
Pull up the turn around.
So George and I are going to watch Jay here and just pepper him with questions as he continues.
Yeah, please. So just one of the cool features about this module and a lot of the other ones is that you can see the anatomy by subtracting or adding back the skin, so you can see all those muscle planes, and they're adding more and more neurovascular structures as well. Here you can see the axillary artery, brachial artery quite nicely.
Try not to see those too much. Great.
And then we could advance to the next.
Well, it looks like we have some retractors. We have the Holman.
Yep.
What order do you put your retractors in? Do you put the Holman in first?
I don't put the Holman in first. I like my posterior inferior retractor in first. I think that's sort of the workhorse or the power in terms of the retracting. And then from there, you can see most of the glenoid once you have that in, and then you can really fine tune where the other retractors go. So this says that, so I mean, I'm aiming to just not entrap the biceps, because usually we have the stump of the biceps up there still, but just between the biceps and the cuff and burying that right over the biceps tendon. So that's in a good spot there.
Jay, that's pretty much a gift. If you can bury the biceps, here's going to pop out at the end of the case. So it's kind of fun when that happens. But I agree with you. I tend to do a posterior inferior retraction, kind of place the humerus posteriorly. And then this superior retraction is optional for me. If I ever have a visitor, I like to put it in to get a good view. But typically, that posterior inferior can go that end.
Yeah.
One thing I wanted to point out, so typically with your head cut, it's going to be really hard, if not impossible, to put in that posterior inferior retractor with the arm in this final sort of externally rotated position. But that's the benefit of the VR module here. You can actually grab the arm and rotate it whichever way we'd want to go. So typically I tell people to keep it more in a sort of flex internally rotated position. You can translate out the humerus, get the position. And then I tell everybody to get the feel of the arm and put the arm where they want to go while pushing on the retractor, just so you're not really crushing or destroying too many things while you're doing it.
George, with robotics coming out, where do you put a retractor for the coracoid?
I'm sorry, can you say that one more time?
With robotics and navigation and MR, when you're exposing the coracoid, where do you put your retractor? How do you do that well?
I typically, my vector incision is very much higher and more lateral. So my incision actually doesn't change too much when I'm going to be moving to put a retractor on it. But I don't put a retractor superiorly. I put one posterior inferiorly and then anterior inferiorly. And for me to view the superior portion of the glenoid, I tilt the bed now. So I really only use typically 2 retractors, and the reasonable one is bed tilt to the contralateral sides. Airplaning, in this case, I would airplane to the right. It's wonderful, if you have 2 assistants, I think it's great to have more retractors, and I typically use 2 assistants try to minimize my retractors. All right.
Perfect. So yeah, we have it, just like Dr. Lohr was mentioning, internally rotated position to get this retractor posterior inferior just over the lip of the posterior inferior glenoid. I usually just like to feel exactly with my left hand as I'm placing it with my right hand, so I don't have to replace it. You could, get it perfect every time.
You like to feel it flip over that posterior inferior labrum, right?
Yeah. So we'll start it in that position, and then we could bring it out with the arm into external rotation. And honestly, sometimes, like especially with the Fukuda retractor, if you use that, you don't really have to actually rotate the arm all that much because the Fukuda can create a little bit of a space for you, and the arm can be left in a more neutral position without potentially stretching the brachial plexus and things like that. So.
Yeah, what retractors do you like to use posteriorly? And if it's a tight shoulder, do you change the retractor you use?
I like it. I've been liking the Fukuda, if the humerus is of the right size. So sometimes the humerus is just too small. Then I think a more powerful solid retractor like a Dara, or even like this. I think this is a Tournier specific retractor, but that retractor is nice. Has a nice lip on, right at the edge of the retractor. But then I think when it comes down to it, removing these retractors is the key to getting your glenoid components in, especially in reverse. So I think just if you're well released circumferentially, you have enough mobility of the humerus to get all your components in.
I think one of the key maneuvers that you did there, which was very subtle, is that you activated the arm position as you externally rotated and as you contract on the retractor. It's really important because when people don't do that, and then you put a lot of tension, I feel like you put a lot of tension in the plexus by doing that. Kind of stabilizing the arm gives the and then tractioning through the proximal aspect of the shoulder, but by releasing the tension in the arm position, you really decrease your overall tension in the plexus. I like your positioning.
And so now we have the Richardson retractor. I also do like this maneuver just so that obviously we can retract the conjoint tendon such that we can really see the extent of the subscapularis and the rotator interval to sort of prepare us for our next move for the releases. There you go. So they want this a little more inferior. And then we can retract it medially. So now we really do have a good look at subscap, the rotator interval here, and usually just with palpation, you can feel the SGHL and MGHL. And so, one other thing, if you can't evert the subscap, then you know that those ligaments are still intact and you need to do more of a release. So I like to use just curved Mayo scissors right to the base of the coracoid there. And then from there, can release inferior from a superior to inferior direction, just along the glenoid, between the glenoid and the subscap, so that you can get a retractor anteriorly as well as you.
Okay, when you take your curved Mayos and you transect the axillary artery, how are you going to get to it?
It's a question for Jake.
Yeah, let's go, Jay. Because you seem to enjoy curved Mayos, which scares the poop out of me, but that's fine.
Yeah, and I mean we need to. We had a case recently where we prophylactically exposed the artery in a fracture situation because the humeral shaft was so medialized and the spike was right up against and kinking the axillary artery. So we just tenotomized the conjoint tendon, tagged that, and then just carefully dissected down to, thankfully we were able to subperiosteally peel the fracture fragment away from the nerve, like the whole plexus and axillary artery. So we didn't need to tag it or anything, but our intention was to get control first, just in case we were to lyse anything by mobilizing the fracture.
Yeah, you can release the pec too if you need more exposure.
So, Jay, what order do you do things? So you've got this exposure now.
Sweet. Yeah, honestly, I like to, once we have conjoint retracted, palpate axillary nerve, blunt a home in just in between capsule and axillary nerve, going somewhat anterior to posterior to protect that. And then I like to do an inferior capsular release right to the anterior inferior glenoid. And then I can connect that up with the rotator interval release. So now we have a full circumferential release of the subscap. I think in anatomics, that's really important for that being a pathologic structure that we need to release in terms of posteriorly subluxed humeral heads, as well as stiffness postoperatively with external rotation stiffness, and just getting a tension-free subscap repair. And for reverses, similarly, just to to really get as little tension as possible on the subscap, because it's obviously going through a much larger arc of motion once you put a reverse in there, and so it's stretched to the extreme, you know, in different arm positions when you use it in reverse.
Ryan, how about yourself? Do you do anything different?
So I don't like using scissors. I just go with electric cautery. I think the dynamic position of the subscapular is really important. So there's sutures on this right now. And if you grab the sutures and pull it actually towards you and drape it across the joint, I just then complete the rotator interval up towards the axilla here of the coracoid process and the CA ligament. And then as long as you don't go deep to that, you can easily just take your cautery right down onto the superior labrum, and then just continue that down all the way to the MGHL. I'm very cautious to go a little bit lower because the nerve can be variably positioned with the arm in this adducted externally rotated position. It's quite close to the inferior labrum here. So I don't think it's all that necessary, to be honest. And then frequently here, I don't even, like, we're not struggling for exposure. I usually, if I don't have to, I don't even put a retractor in the front. Another nice trick or tip too is if you throw like a towel or an interface over the drape here and you put your retractors in, you can actually just bunch it and clip it all over the place. So a lot of times when people are starting out, they don't have that much help. And so if you can find some clever ways to pin some things and get some nice exposure that way, I think it's also really
Excellent. I think what we're learning here is everyone has a little bit of a different way of doing it. What I tend to do, the first thing I do, I identify the roll up the door of the subscapular, the orcohumeral ligament reach right down to the base of the coracoid, and then just excise the biceps and the posterior labrum all the way around. And typically I separate the anterior labrum from the capsule, develop that interval, put a Batman retractor, and I tend not to do this inferior capsule or capsulotomy. I just do a capsule leads off the glenoid here and a capsule leads off the reverse. And typically with the reverses, I'll actually take the capsule off a little more posteriorly. However, with anatomics, I typically go to 6 o'clock, maybe a little past 6 o'clock. You kind of gauge it based on their tension. So it's a very stiff shoulder, I'll give you more of a capsule release as anatomic. And if it's a more pliable shoulder, I'm probably gonna be a little bit.
Or do you ever do any posterior capsular releases on a stiff shoulder? Do you ever strip the capsule in the back?
Absolutely, yeah. So if it's a stiff shoulder and I can't translate the down head posteriorly, then I'll definitely release the posterior capsule. The most of the case is really routinely. Sorry, go ahead.
How do you do that?
I was just with a Bovie.
Yeah.
So I just use a Bovie. The key thing you have to be careful of, and I've done this before, is you have that, your suprascapular coming around the spinal glenoid notch there.
Yep.
Had a few times, and once you get it, it attracts the supraspinous muscle.
Yep.
It's a little bit fussy to get it. Actually, it happened to me today on a revision, and so a complex case. So essentially, what we did, the fellow had a great idea of bending the cautery, so we just bent it out the corner
and wrap it around. Yeah.
Jane, you use curved Mayos for this whole portion of the case as well?
Not curved Mayos, but I think knife for capsular. I don't know. It feels really controlled, especially for getting that sort of posterior superior retractor and in revision settings, just using a long-handled 15 blade to make a small rent in the capsule just to get your retractors up there can be sort of save time, and the retractor slipping in and out and things like that.
Yep.
But no, Bovie's, I don't know, I like Bovie's, to me, just a safer way to have a bloodless exposure and kind of know where you are.
Before we go to the next module, maybe as we're transitioning, George, I would love to know, like I had a bunch of revisions today too. What's your best technique for the viewers on how to get glenoid exposure, especially for when that scarred posterior capsule that sometimes has HO? What are your steps to kind of expose that and still get retractors in?
I think the key obviously is you start with the humeral. In general, with most of my revisions now, I'd say far majority of them, I'm leaving the humeral component in. When I first started doing revisions, first thing I do is I do the remove the humeral component. By leaving the humeral component in, I find I can get a little bit better traction. I can get retractors and I can leave it on that. And so that's one way you get better glenoid exposure, being able to quickly leave it without having to crush the glenoid. So leave your humeral component in if at all possible. The second thing, and Jay had a very good point, it's different with revisions and anatomics in that the recess between the labrum and capsule, while it's present in primary cases, in most revision cases, it's conflict. It's hard to get your retractors into that recess. And so I do what, very similar to what Jay said, is I actually get a scalpel or a bovie to create an capsulotomy here so I can actually get my retractor in. And then once I get my Darrow retractor in, I actually twist the retractor. Sorry. Oops. I think I zoomed. I'm out of field. I'm coming back. Give me a second.
That's amazing. George can operate from across the room and quickly get to the other side.
Yeah.
So with this retractor that we have in here, I'll get my assistant to grab it and just slightly twist it. And when you twist it, open up space along the inferior portion of the retractor so you can go ahead and use your bovie there. And then when you twist it clockwise, you open space at the top. So it allows you to get space.
All right, awesome. Shall we go to the anatomic module?
Yeah, that'd be great.
Yeah.
All right, so Danny, as they're hopping over to the anatomic module, what do you see coming down the pike for VR? Where do you think we're going to be going from not only your ventures but also from an ASES perspective?
Yeah, so as people are transitioning over, I mean, the big thing for us really is facilitating a world where it's more free because surgeons do different things. And I'll turn my camera on as people are moving over to the module, to the other module. So yeah, it's a great question, Chris. And I think that, you know, the example that we're having today with George and Jay and Ryan is that everybody does something slightly different. And surgery is an art, not a science. So having something that's prescriptive, which is telling you exactly what to do, is not facilitating a really rich, nurturing, or educational environment. So having something that's a little bit more free is sort of the direction that we've sort of taken from the beginning, and it's just becoming more and more free as we move forward. I think those are important educational considerations that we've started with early, and we're just accelerating those moving into the next few years.
And maybe for people who haven't used your technology, what are like some of the modules that they can get their hands on and start practicing on?
Yeah, so we've got a full complement of shoulder arthroplasty and arthroscopy. And on the arthroplasty side, from a anatomic to reverse, anatomic arthroplasty has some glenoid deformity as well, but mostly the glenoid deformities exist in the reverse library of cases we have. And we have all, you know, all the Walsh classification, all the Favard classification of glenoids in those modules. They can practice just starting with understanding the three-dimensional orientation of what that deformity actually looks like. I don't know about you, but I haven't seen an E4 in practice. And these are rare things that perhaps it saw me and I didn't see it, as I heard once somebody famously say. But I think having a really deep three-dimensional understanding of some of these pathologies is really good for learning as well as understanding what to do in the OR. You know, as we become more and more reliant on technology, we still have to understand the three-dimensional spatial awareness of what things actually look when they're normal and abnormal. And then, so that's on the arthroplasty side. And the arthroscopy side, you know, we built our first collaboration with ASES for both the left and right shoulder when it comes to diagnostic arthroscopy. And what we did there, which was unique, is I don't know about you, but nobody spoke about ambidexterity a lot when I was a resident. And I think it's a skill that you sort of realize that you may not have well developed when you become a surgeon, because we operate on right and left shoulders and right and left elbows. So doing that with ASES to say we should have a right and a left shoulder is something everybody has access to. In addition to that, we have a rotator cuff repair module. Again, going through the nuances of where to place your portals, where to put your camera, deciding on the type of view that would be optimal. Again, getting those skills and practice if you're a learning or an early career surgeon and maybe doesn't have a lot of arthroscopy experience, or it's something that you want to pick up, or importantly, as a resident early in your career to learn those as well. So that's all available right now to the ASES members.
Okay, real quick, Mike's in the post. The code is 5383 for those who need to use that to join the modules.
We are all in.
Okay, let's do it then. We are ready.
Let's do it.
Jay, I'm going to hand over the controls to you, or is it Ryan who's going to drive?
Oh, let's let Jay go for it again.
All right.
You have the con.
I have the power. Okay, yeah, so this is just the first of, there's 4 options, and we're going to go through 2 of them today.
Let's start over here.
There we are. Great.
Great.
Yeah, so here we have it. So we did part of the work in the other module, but so this is now, well, nearly fully exposed. It doesn't look all the way exposed. So we'll move on to, this is an interesting and I think unique part of the system in terms of assessing the backside radius of curvature of these implants and how it's going to best fit each patient. So this is showing a radius of 40. And this is inferior superior. My thumb side is anterior posterior. So you're really measuring both radii of curvature and just trying to pick the best one so that you can minimize reaming. So we'll go with a 40 for this patient. And this is, so we can check there and we feel like that's a good fit. So we can move forward with a 40. And you're really just checking for rocking of this on the glenoid surface.
It's interesting. Yeah. So Jay, when I first started using these instruments, I was using that fairly frequently. And now with the preoperative planning software, you can kind of pick your backside radius on your polyethylene implant and kind of avoid a step intraoperatively, so save some time.
Yeah, that's awesome. Which one are you using most frequently?
I'm using the higher radius in general.
Okay.
And
Okay.
minimize the amount of reaming. And why is it important to minimize reaming?
You know, I think that there's a couple reasons. One, you know, we don't want to violate subchondral bone theoretically in terms of just support for the glenoid implant. And then, you know, another reason could be just you don't want to overly medialize the joint. So if we're able to restore this joint back to potentially where it normally was the best we can, then some of the soft tissue should be, you know, as good as it could be. And we probably have a ways to go to dial it in perfectly for every patient, given the amount of erosion, but that would be my theory. What are your thoughts?
Well, I think you nailed it with the first one. In general, Gilles Walsh reported his series of long-term outcome after polyethylene implants, and they found when they reamed too much and they got into the cancellous bone, the implants would eventually migrate immediately over time. So preserving that subcortical bone that's very dense is ideal. And so by minimizing the reaming, you can preserve that. The downside of that is most of these implants, polyethylene implants, are about 4 millimeters thick. So if you truly have an A1 deformity and you minimize the reaming, truthfully, you're probably lateralizing the joint a little bit. And so that's
Yeah.
something to adapt on the humeral side. So it'd be nice if we could make our polyethylene implants or have an alternate bearing surface that was a little bit thinner.
Yeah.
Nice. Good exposure.
Awesome. Thank you with your help. So yeah, we've selected our radius of curvature, and then now we're selecting the actual size of the implant. So we can
Hey, Jay,
toggle.
let me just pull this out so that
Oh
people
yeah,
can see what it looks like. This is one of the benefits of VR here too. So, you know, normally we're doing it in the patient, but here we can just get a better appreciation of how that implant fits, where we want to put it. And again, we get that red light indicator. So I'm just looking at your hand, maybe rotate it a little bit and see if it.
I don't know, Jay, it looks pretty good to me.
Yeah, try hitting the trigger again. Let's see. It wants it perfect.
Interesting.
Gosh, I feel like I'm back with Jay when he did his residency at Duke. Torture.
Let's see. Let's go smaller. See, maybe it wants a smaller one.
There you go.
There you go.
It's the right size, but it wants it a little bit more centered.
Just a little better.
Be better, Jay.
Wants a little bit of that. Yeah, what are, so, in terms of tilt of the implant,
There you go.
so that to me looks too posterior, but I think we'll take it.
Well, I don't know. Let's have a look.
Yeah, I would say in general, like
Oh, no,
in
that looks pretty good.
B2s,
Yeah.
in B2s, if I'm gonna bias, I bias slightly posterior. If I want it perfect, but if I had to bias, I bias slightly posterior because the head's used to being posterior, and so
Right.
Yeah.
that's why I put the polyethylene a little posterior. If it's required, ideally it's better dead center. But I agree with you. This looks a little bit posterior inferior. I probably would have rotated it about an hour counterclockwise and moved it a little bit up, but.
Same with you for reverse, George. If you're going to bias, obviously dead center or dead perfect is great, but for reverse, you're going to bias posterior or anterior.
So, I used to put it dead center, but now I'm biasing a little bit more posterior inferior for really two reasons. One is I improved my external rotation, improved my extension, and also decreased my incidence of subcoracoid impingement or impingement against the conjoint tendon. The
Yep.
more anterior you put your base plate or your glenosphere, the more likely are you get impingement with the lesser and the conjoint tendon.
Yeah,
So
could not
I'm
agree
starting to
more.
watch that during every surgery just because I don't like patients coming back with anterior shoulder pain. Great. All right, let's pin it.
So we can go to the next.
George, as he's pinning this, you're assessing the conjoin during every case, I'm guessing, right? How often are you doing a little, I don't know, like lengthening of the conjoin for a tight conjoin?
It's funny. Whenever I see any contact, I'm doing that. So I'm essentially pie crusting the conjoint tendon, very similar to what pediatric surgeons do with the Achilles. So if I see any contact with the lesser and the conjoint tendon in internal rotation, I'll pie crust it.
Yeah, I had 5 cases today and I did it 3 of the times. So
It's still I'm still getting used to it because sometimes I forget to assess it, and it's embarrassing to say that, but sometimes I forget to assess that internal rotation. But when I remember, which is the far majority of the time, it's pretty frequent for me to do the release now.
Perfect. So here, just, placing our central pin.
Actually, that looks perfect.
Yeah, that does look nice.
That does look nice.
Very nice.
And here we went, bicortical. I know this is designed to be essentially bone grafted hybrid fixation. This component, curious if there are times when you're cementing all of, the peripheral pegs as well as the central, or do you always bone graft the central? What's your theory on that?
So I have a very strong opinion on that. I mean, I believe bone can interdigitate within those phalanges on these anchor pegs or cortilock type pegs, but I don't believe bone actually heals to polyethylene. So I actually cement all 4 holes. So I'll cement the central one, the superior, the anterior, and posterior ones. And that's why when I put my guide pin in, I typically do not go bicortical because I don't like the
Got it.
extruding out that medial hole.
Yeah.
So Ian Trail from the United Kingdom did a nice radiostereometric analysis study looking specifically at central peg cementing, and he found when he cemented the central peg, the implants didn't migrate as much. Without central peg cementing, there was a high incidence or a higher incidence of migration.
Okay.
And
Interesting.
additionally, when you cement the central peg, you don't have to worry about central peg osteolysis either.
well, that's
Yeah.
100% right. Anytime you do these revisions with a non-cemented central peg, you have this huge, almost like giant cell reaction. So I started doing the same thing. I cement all of them.
So we actually, one of my fellows from Australia is looking up our central peg cementing to see how they're doing. So hopefully I'll be able to provide you with some data when we do this again in a year.
Awesome.
Great. Oh, what was that there? You looked inside the bone.
So now we have our reamer here. And one of the nice things about this in VR, you can really assess your depth in live time. And maybe in the future, that's where navigation is going to be really nice, or robotics, because, obviously the back and forth checking of your reamed surface and trying to get to the perfect depth just takes sometimes some guesswork initially while the reamer is sort of blocking your view. So I think that would be really nice.
So Jay, how often are you using some of the enabling technologies, like mixed reality or patient-specific guides or robotics? in your practice?
Honestly, it's been maybe 1 out of 30. Mostly the patient-specific guide's really just for the custom implants, if you can even count that. And then most of the technology is really in the preoperative planning, which we've had around for several years now. So nothing that's extremely new in terms of AR or robotics just yet.
How about
What
yourself,
about
Ryan?
you?
Zero. Yeah, I don't I don't use any of the augmented mixed robotic any sort of stuff like that. No. I just rely on planning essentially.
I think preoperative planning has been a game changer for me, certainly. But in the really deformed cases, I will still order a PSI guide. It's rare, but I still will. And in those cases where I'm using a custom implant, I'm using it quite frequently. At one point in time, I was using mixed reality fairly frequently. However, yeah, you may know that Microsoft is now potentially going to discontinue the use of the HoloLens, so that
Yes.
puts us out for mixed reality.
George, what has
Yeah.
prop planning done to change your practice? Do you feel like you use different components? Like, what's the big advantage you've had with it?
With preoperative planning,
Yep.
yeah, so I
I feel
mean,
like I use way more wedges ever since I started prop planning every case.
well, it's funny, I can't remember a time when I didn't pre-op. So I started with the software, like with the startup when we did preoperative planning. I believe it was 12 years ago now. So I've been using planning for quite some time. When we first developed the software, actually, we only ever developed it for anatomic, and we thought, why would you ever need it for reverse? So the first iteration was for anatomics, and then we started going into reverse after that. But I think personally, it's helped decrease my early postoperative complications such as base plate failure. I'm more consistent where trying to recreate the RSA angle the base plate appropriately. I'm identifying the challenges of where the bone is missing. Where do I want to have my start point? Where am I finding the best bone? And it's made me much more efficient in the operating room. So before we start a surgery, I have a post-it that has all the implants I want ready. And the nurse will have them all ready to go. The reamers are all set up. So I think it's much more efficient in the operating room.
No, great points.
All right.
Awesome.
Jay, that's a good job.
So we've reamed, and now we're just drilling for that central fixation, like you were discussing in terms of the cementing versus bone grafting. So it's a hard stop.
I was wondering, everyone, I just want to take a quick poll of everyone in the OR here. Maybe we'll start with Jay and then we'll do George. What percent of your cases are you doing anatomics? How many anatomics did you say that you do?
Probably 50%.
50%? How about you, George?
Geez. I'm thinking I'm probably 85, 90% reverses.
Yeah.
I still believe in anatomics. So if a patient's got a good rotator cuff and they got good bone, whether it's an A1 or a B1 or a B2, I still do an anatomic. I'll do an anatomic with a posterior wedge also. I think it's just the nature of my practice. It's probably just a little more reverse, but I think an anatomic's a great implant.
Yeah, no, I'm just curious because different practice patterns, different philosophies, things like that. I would say I maybe do 2 or 3 anatomics a year, and it's probably just based on my practice pattern as well.
Yeah. What are your thresholds for either subluxation or glenoid deformity or medialization? Like what are the sort of red flags for you, both of you in your practice to say that this person would do poorly with an anatomic?
I think for me, so I don't do it with a medialized glenoid. So if it's an A2 gets a reverse shoulder replacement for me. If they're
Okay.
B1s, B2s, and I can correct them to less than 5 degrees of retroversion, for me, that's a good anatomic as long as they have good soft tissue. So I look on the sagittal oblique views on the CT scan to
Yeah.
cuff and fat infiltration. And so if they've got good bone, or they got correctable bone, and they have good bone, and they have good soft tissues, those patients will get an anatomic.
Yeah, that's right. I essentially agree with that. I think, age might also even play a little bit of a factor for me. I've been really influenced by this discussion of implant longevity and revision risk. So my practice has really moved to, alternate bearing surfaces and pyrocarbon hemiarthroplasty for younger patients with intact cuff and, not much deformity as you just described, George. And then honestly, I am a big believer in reverse shoulder arthroplasty for really any medialized deformities.
The only other thing I would add is if patients have cystic bone disease, so they may have
Yes.
A1, correctable B2, but if they got cysts in the glenoid, Mark Frankel has shown that your risk of glenoid migration and glenoid failure is higher. So those are some other cases where I'd consider going to a reverse.
Yeah, rather than a
Okay,
face.
awesome. Start there, and then that won't lock in our rotation yet, but then we can get the second easiest one anteriorly if it goes in the guide.
I do the
There
same
it
order,
is.
anterior, inferior, and then the posterior inferior last. And sometimes if you can't get the posterior inferior, what I'll do is I'll just put my hand on the back part of the scapula and push the scapula forward. It just gives you enough room to get that posterior inferior peg hole drilled.
Oh, nice.
Just a little bit of a how's she doing push here.
Okay, so that was. Oh, nice. Yeah, and then just checking each hole with the a Fraser tip suction just to make sure we haven't perforated. And if we have perforated a hole and we're planning to cement that hole, just use a little bit of bone from the humeral head to just pack it in there.
Nice.
All right, we have.
If you've perforated, do you just let that hole uncemented? Do you guys let those holes uncemented if you've perforated just one peripheral hole?
No, I think I need as much fixation on this base plate as possible because I'm just waiting for this thing to start failing. So yeah, I use everything.
Ryan, not a fan of the anatomy.
Ryan.
Jeez.
No, I know. I'm trying to stay, objective here, but I'm doing this.
Well, we have about next module, and George, maybe I could ask you two questions as we're going to the next module. For those of you who are like Ryan who do zero anatomics, any tips for your humeral head cut? Because we haven't talked about anatomics specifically.
I mean, I think the humeral head cut is so based on the implant system that you're using. So if you're using a inlay system that's diaphyseal fitting, I think you can probably get away with a little bit more for the rest of the time. If you have a metaphyseal fitting inlay system, you probably go a little bit higher. And if you have an onlay system, you get the advantage of making a very aggressive cut. And I tend to do my version anatomically. So for you use retro version, I typically do. I have to set them all.
Awesome. Thank you.
So are you using any guides when you're making your haircut, or do you just base it on the anatomic position of the cartilage surface and the cut?
So I actually do software assisted cuts. So I look at my stuff on the software. I see where the plane of my osteotomy is going to be. And then I replicate that kind of surgery. How I replicate that is the first thing I used to do is if you do the inferior tapestry is to remove the osteophytes. Now what I do is actually I leave a lot of those osteophytes on because they're kind of landmarks of where I can make my osteotomy. So I'll look at my preoperative planning software, and if my osteotomy is 5 millimeters above a very prominent osteophyte, I'll keep that osteophyte and just put a bovie mark 5 millimeters above that so I can use that as a reference for my exit point for my osteotomy and then remove the osteophytes.
Nice.
The other thing I've actually, before I even remove the osteophytes, sometimes it's great if you don't have another assistant and you use a Batman retractor, you can put a Batman retractor underneath those medial calcar osteophytes, and it kind of really exposes the shoulder quite nicely.
Nice.
And then remove them at the end of the case.
That's nice.
Great, that looks good.
Yeah, so we like our trial. We got a 61%, which is pretty good. It's a pass, I think, in the precision world.
Three surgeons have got 61%.
And so we can go.
I thought you all do.
I think we're gathering too much. This looks perfect.
I don't know.
I think it was the time. I think it was the time.
I think I need to go back to school.
All right. Maybe we all go to the last module. We got
Let's talk this
less
last.
than 15 minutes. George, can you hear me?
Yeah, I can hear you.
Les, we're getting this module set up. Is there a world where we don't do any anatomics and it's just reverses and pyrocarbons? I know it's a question that people say all the time, but as someone who's as innovative and research as you, do you think that ever happens?
You know, I don't think it's going to happen. I think even with pyrocarbon, you're going to get erosion. I would expect that if I was to look into my crystal ball, I think what's going to happen is that pyrocarbon is still going to stay for the younger patients because you're not going to get complete pain relief. And your slightly older 65, 70-year-old patients that have good bone and good soft tissue, I think an anatomic's going to work well for them. If you actually look at the Australian Joint Registry, it's amazing that the best performing implants are as a stemless anatomic has the lowest revision rate, lower than a reverse. So I think anatomics will still have a role to play. And the thing I think about often is that my patients that are getting an anatomic now are arguably my best patients. So if I looked at 20 years ago when I was doing anatomics, I didn't even know what a B3 was, and I was doing an anatomic and a B3. And so those patients had a higher failure rate. I was doing partial corrections, leaving them, 20 degrees retroverted, but we don't do those things anymore. So I think our anatomics are going to have better survivability going forward.
Yeah, so here you can really see that erosion pattern nicely here. So it is somewhat biconcave superiorly. So E2 glenoid. And so a full wedge or half wedge for both of you, preference or whatever fits better. I know you get more lateralization with the full.
Yeah, I very rarely use the half wedge base plates. I like the lateralization I get with the full wedge. The system I use right now has an inlay humerus, and so with an inlay humerus, I have the option of getting more lateralization on the glenoid side, so I like to take that.
Nice.
But this is a really nice exposure. You can see how the cut protector is placed onto the humeral cut, and it's essentially perpendicular with the face of the glenoid, so it's going to give you a nice straight shot. So the humerus is in a external rotation to give you that shot. And sometimes I find it's a little bit easier to raise the elbow up a little bit and takes a little bit of tension off the axial nerve, because the more extended you keep the humerus, the more tension there is on the nerve. But that's a good exposure.
Nice. I mean, we can leave it out here, maybe. So this is our pin guide. I know there's 0 and 10 degrees. This looks symmetric. So this is probably the 0 degree position of base plates for you both. More central, flush with the inferior glenoid, overhanging inferior. What's your target with the sphere?
Well, with the base plate, I like to place the base plate, the inferior portion of the base plate, right along the inferior portion of the glenoid. So I've exposed that area, ideally dead center. If my preoperative plan says that I'm going to get impingement more posterior, then I'll slide it a little more posterior. But the challenge with putting it posterior is it makes everything a little bit harder. It's the hardest place to put the base plate is posterior. You're dealing with your retractors.
It is.
So
And
it works.
the can also push your guide forward. So you have to be very conscious that you've exposed the entirety of the glenoid, including the posterior inferior aspects, so you know exactly where you're putting it.
And then I think Pascal Boileau did a really good job talking about the reverse shoulder angle, and that's actually helped me. So I try to have my base plate axis or my screw axis, my central post axis parallel to the floor of the supraspinous fossa, as you can see right here. And the preoperative planning software helps me to do that. I really want to avoid any superior inclination of my base plate. I think Bob Tashin has shown us that superior inclination leads to an increased risk of instability, also base plate failure. So only good things can happen with a neutral base plate or slightly declined.
Jay, where are you going to put?
Yeah, I was aiming for a slightly posterior inferior for the reasons mentioned earlier. Get clearance and external rotation, adduction on the sort of the lateral neck of the scapula, and potentially avoid coracoid improvement. That's fairly centered in this case, but we'll buy it.
Yeah.
It is. And one thing, you didn't fall into the trap here, but whenever you have this superior erosive wear pattern, you really have to be conscious of the guide that you're using, what sort of preoperative planning you've done so that you do not tilt this into an erroneous, superiorly tilted oriented position. Because right now it's nice, we can cheat, but when it's inside, we can't see that supraspinatus fossa or reference anything. And Walsh and Boileau showed that with an E1, it's very easy to do that. But I think also with an E2, it's easy to do that as well. And George and I kind of have this nice little paper coming out about visual assessment and how easy it is to superiorly tilt the base plate.
Yeah. Is there anything, intraoperatively for version we could use as Matton's point? We can reference that to have a ballpark of whether our version is near neutral. Anything intraoperatively that you can use other than preoperative planning to feel like your inclination is in the ballpark. Just referencing.
Ryan, why don't you take that question?
For version, I think version is an interesting topic. I don't necessarily know how much version really matters as long as you're getting good primary base plate fixation and you're not impinging anywhere. Even if it's retroverted, I will keep this and match the retroversion and just maximize backside base plate contact. I do not use augments for retroversion. I'll use it for superior wear patterns. I use a different system than this predominantly, but and similarly, if you have erosion, there's good fixation patterns with alternate glenoid positions as well. This concept of an alternate center line. So there's different scenarios.
Awesome.
Great. All right.
I think it ended up in a touch of superior tilt, but for the good thing about VR is you can make some errors, and we can look at them all together. So this is nice for version. I mean, this is coming right out at Mattson's point, right at the anterior sort of neck of the anterior base of the vault of the glenoid there. You can actually digitally palpate that intraoperatively as well. And then
Digitally with
so
your
this
finger.
is just specific to the full wedge. What was that?
I was just joking. You said digital, so I mean digital with your finger, not digital with like digital software.
That implies.
That was an awesome bad joke.
Where did I get that from? All right, friends. So here we have our, adjustable reamer, 55, 35, or I think 30 degrees. All right.
Yep. So augment's going pretty much straight superior.
Auditory feedback is really important here as well as the visual feedback to see how much you're reaming. But I like this with it.
Ron, do you have any base plate contact you're striving for? If you had to just give a ballpark, 100% obviously, but what's your minimal acceptance?
Yeah, I like 75% with a good central fixation and 2 points of peripheral fixation at least. I try to go for as many as possible, but sometimes you have these people with these really narrow glenoids and you need to try to optimize it possible. Planning will obviously help with that, but yeah, my number is probably about 75. Perfect. Oh my goodness.
Look at that.
I was
That's
getting
beautiful,
anxious
Jack.
watching the phone come out. Okay, great.
Beautiful.
And this is the
George, when are you using a half wedge? You talked about
in-
half wedge and full wedges. When's your half wedge utilization?
My half wedge utilization is 0.
Zero. Okay, awesome.
I think
Definitive.
I don't use a half wedge. I've been very happy with the full wedge implant. In fact, I think I need more wedges. This full wedge right now is a 15 UV wedge. I'd love to have 25.
I've only found a few instances that it actually sort of works for me, maybe like a post-traumatic sort of scenario or like a glenoid fracture scenario where you can add a stable buttress if you don't have good bone grafting support that you want to add to it. Like Danny said, maybe a funny E4 type wear pattern if you ever come across it and they don't have a brachial plexus injury, that sort of stuff.
Chris, how about you? How often do you use a half wedge?
Yeah, same thing as Ryan just said. I use it a lot for significant glenoid bone loss. I use it for revisions actually quite often because I feel like it sometimes fits just polywear and for fractures. I do a lot of fracture work and a lot of like anterior Bankart fractures that require reverses. The half wedge works really well.
Yeah,
All
good
right, let's
revision too. Sometimes it fits in there nicely.
drill the central boss hole now, and then we'll put our implant in there.
Sure.
You folks do commonly use a central post or central screw? What is your preference? And does it matter?
I prefer a screw for primaries and a post for revisions.
Is that around the room? Everyone feels the same way?
It's interesting. Yeah, I'm fairly similar. And for most of my primaries, I'll use a screw. Uh, and any revisions with bone loss, I'm more likely to use a post. If a revision's more like has a reasonable amount of vault bone, then I'll go to a screw. But in general, for my most complex revisions, I'll use a post.
It doesn't matter if it's a keel or if it's a poly peg, you're going to use the same algorithm?
If it's say if I'm revising a keel or similar one of these quarter lock implants, typically the boss on this implant's about 11 millimeters in diameter. So the boss functions a little bit like the post, and then I still use a screw, especially if the bone's preserved. But if there's cavitary bone loss, I'm more likely to go to a post. But I think there's surgeons that are very comfortable using screws in all revisions too. That's just my personal preference.
Yeah. I guess what we're all just kind of saying is we're trying to optimize contact and bony growth potential.
Yeah, stability.
All right.
Awesome. Measure this.
Gage, haven't used that before.
Jay's getting some lung tissue.
Okay, once it all the way in. So we're measuring around
There,
35.
at
So
the
it's
preoperative planning
adequate
software,
length.
screw length, and have it all ready to go.
I bet it's going to be 30. Let's see.
This is where Ryan yells at his scrub for not being ready.
That's right. I feel it in my chest already, Chris.
Hell, I could tell the anxiety.
I don't know, Mike, can you get any closer?
So yeah, so in this case, we're almost done.
It's interesting. With this
Right.
system, that boss does have a little press fit there, so it can be at times if you have sclerotic bone, it may be a little bit challenging to seat the base plate. So I usually just get a little mallet and give this a little hit to seat that down.
Oh, nice. Okay. And that's towards the end once the boss is engaging.
Yep. Great.
Looks good.
Yeah, so that's fully seated there.
If you can pull back the inserter there. Yeah, there you go.
Are you all using every screw hole, using just some?
You know, with this particular system, if I got a solid central screw, and it looks like Jay did a great job here. I'm just using two screws. I'm using the superior screw, which I typically always place short. So my superior screw is usually a 22, and then I use an inferior screw. So typically two screws. But if the bone quality is poor, then I'm going to add screws.
George, if you're gonna, so for this implant, if I remember this one correctly, the central or the superior screw hole is a non-locker, right?
Yeah.
So you're gonna use a short non-locker.
Yes.
Interesting, cool.
George, I like what you said about the top screw being short. Can you elaborate on that? Why do you do that?
There's a theoretical risk of acromial insufficiency fractures, and so with this central 6-5 screw, it has such great compression. All I need is the peripheral screws to provide some counter rotation, and so the short one at the top and a locking one at the bottom. Arguably, you probably don't even need one at the top.
That's a great point. Yeah, technically, like an over a 26 oriented towards the scapular spine can predispose you to a scapular spine fracture. Theoretically.
So nice and short on this one, and then a nice long one on the bottom. I like to put my screws just a little bit divergent because I don't want to engage that central 6-5 screw because that's going to give me all my great compression.
And George, so we talked a little bit about, I know I'm jumping ahead, I apologize, but we talked a little bit about anterior shoulder pain, conjoint tendon impingement. I think you used to use 42s on the majority of your patients. Are you still doing that? Did I hear that incorrectly from one of your great talks?
You're right. I mean, so for most larger patients, I'm still using a 42, and for very large patients, I'll use a 42 lateralized. Um, And so, I mean, I'm trying my best to minimize that anterior shoulder pain. So I'm assessing that conjoint tendon, releasing it if I need to, trying to place my base plate posterior and inferior. We did a little study. If you place the base plate central versus inferior, the central seemed to have a greater rate of impingement. And
Hmm.
so that's why I'm placing it low and posterior. And you can adjust your version also. So if you really want to minimize it, you make a more antiverted humeral cut. That'll also let your lesser tuberosity escape underneath it. The more retroverted the cut, the more the tuberosity comes anterior.
Yeah. Yeah. Good.
Also, I mean, some systems have those trays, eccentric trays, so you can adjust your eccentricity, move the tray to the front anteriorly, and that's also going to decrease your impingement. It's interesting when about 5 years ago, before we really were talking about conjoint tendon impingement, I used to think it was the subscap that was failing or the subscap that was causing pain. Like you get these patients that come back after 3 or 4 months having anterior shoulder pain. I thought they may have ruptured their subscap, but I think now certainly it's conjoint tendon impingement.
Have you taken these patient backs and released the conjoint tendon or pie-crusted it?
So I've taken a few patients back. Usually, what I'll do is, and I'm not there's no good science behind this. I'll ask them if they can live with the symptoms, and if they can, I do nothing. It usually gets better, and if it doesn't get better and they can't live with, I do a steroid injection in clinic at the maximum point of tenderness, and that actually works in the majority of patients. And in the ones that it doesn't work, I do take them to the operating room, and you can do it open or arthroscopic, but I do a full release. If they're going to the operating room, I don't want to have any impingement, so I'll do a complete release.
You take it right off the base of the coracoid, huh?
Take it right off the tip of the coracoid.
Yeah, I do the same thing, and I can't believe how good patients do after that. It like
It's,
sometimes changes their life.
it's interesting. They'll be better, in the if you didn't use a block in the recovery room, they feel the pain's better. It's amazing.
Yeah,
It's unbelievable.
we're collecting our series Basselman, I and JP and Evan O'Donnell on this, and we have a mix of open and arthroscopic, and often I'll also kind of nibble away the coracoid process as well for these people rather than just the conjoint release. Do you guys ever reattach the conjoint tendon anywhere, or do you just let it fly?
So I've done it arthroscopically and I just let it fly. The interesting thing is in the cases that I've done arthroscopically, you'll see there's a hyperemic, I haven't done a large number, maybe 3 or 4. There's a hyperemic bursa right on top of the tuberosity, and you enter into it and you just debride it. And I burr down the lesser, and then I just release the conjoint. But I haven't done anything to the coracoid. I just burr the lesser down. It usually seems that the subscap has failed also.
I can't even think how you'd be able to do that arthroscopically. That would just, holy moly.
No, it's
fun.
easy, man. Jay will show you next year.
Oh, thank you. That's how I spent his entire residency, him just teaching me. All right. Well, I think we're a little past 8 o'clock. Any closing remarks from you all? Amazing job. Amazing job.
Good job, Dave.
Good job, Jay. 2 joints and exposure in under an hour.
And George, Dr. Wall.
Sign them up.
I was just saying, George, thank you so much for joining us. This was
My
just
pleasure.
such an awesome session, and so many people can get so much out of it. So thank you for taking your holiday week out to spend time with us.
Absolutely. Thank you for inviting me. And thanks to the ASES for organizing this, and to Precision OS.
Thank you, everybody.
All right. Cheers.
Thank you, everyone.
Good job, guys.
Guys, that was awesome. Oh man, it was great. Thank you.